Hello, friends. Today we are going to discuss management strategies for neovascular ARMD. We are specifically dealing with neovascular subfoveal and juxtafoveal ARMD because those are treated differently, which is with anti-VEGF agents. All these patients, whether they are predominantly classic CNVM, progressive occult CNVM, progressive minimally classic CNVM, all three categories are treated with 3 loading doses of anti-VEGF agents and are then followed up on a regular basis with treatment as required on a long-term basis. The various treatment options we will discuss later. There is, however, a need to individualize the approach to management of neovascular ARMD. And why is that? The answer is obvious in the SUSTAIN study, which showed us that 20% of patients need no retreatments after the first 3 injections. At the other end of the spectrum, you have patients who required more than 5 treatments within the same 1 year after the loading dose. And that constitutes another 20% of patients. The rest of the patients fall in between. Just to show you a patient who responded to 1 injection, but that is not the usual scheme of things. So how should you approach your patient? Well, after you've given the first 3 injections, you follow up the patient at month 3. At month 3, you check what is the vision status? Is it stable or improved? What is the OCT status? Is the lesion dry? If the lesion is dry, follow up this patient monthly with PRN treatment if required. If there is no recurrence within the next 3 months, continue a monitor and extend approach with follow-up intervals progressively increasing to 6, 8, 10, and finally 12 weeks. But that's a maximum of 3 months. If a recurrence occurs during this follow-up, you treat the patient with a PRN treatment and then do monthly follow-ups and give treatment as required during this period. Patients who require a PRN treatment with ranibizumab on more than 8 weekly basis should be considered for a PRN aflibercept. That is if you started with ranibizumab or bevacizumab previously. One would say, why not treat and extend regime? Well, I would not give treat and extend regime as a routine, but I believe that's a good alternative for patients who are one-eyed and who have now developed a dry lesion after their treatment. The loading dose that you give could be of any of the anti-VEGF drugs, whether you start with bevacizumab or ranibizumab or aflibercept. I personally try to avoid aflibercept because of the higher risk of geographic atrophy in long-term intensive use of aflibercept in Asian patients. This is my belief, and the basis of the belief is this chart, which is the VIEW 1 and the VIEW 2 trials. The VIEW 2 trials had patients who were Asian origin also, a significant percentage. And what you see is that in the VIEW 2 trials, 2 milligrams of aflibercept given 4 weekly was not the best dose. It had the worst visual outcomes. However, it had the best drying of the lesion. So now what happens? You're getting the worst visual outcome, the best drying. To my mind, it means that the lesion is causing some kind of a geographic atrophy. I'm sorry, I didn't realize I hadn't put it on the slideshow. I've just put it onto that, and you can see it much bigger now. And you can see this. The maximum drying is with 2Q4. The worst visual outcome is with 2Q4. Now, when you give a patient, now why do I not like to give treat and extend as a routine? Now, imagine a patient like this receives 1 injection for a recurrence. No treatment is needed for the next 6 months. If we had started treating this patient on treat and extend, by now an extra 4 injections would have been given to this patient. The second group of patients is more common, and this is that at month 3 after the first 3 loading doses, the vision may be improved or stable, but the lesion is not dry. There is either intraretinal or subretinal fluid still present. Continue the monthly treatment. If the lesion dries in the next 3 months, go back to the regime we talked about of a PRN with monitor and extend. But if it does not dry and the lesion has now become stable, that means there is no change in either the intraretinal fluid or the subretinal fluid, and they're remaining same level between OCTs, I would put this patient on a treat and extend regime and increase the duration of follow injections from 4 to 6 weeks, then 8 weeks, 10 weeks, till we reach quarterly injections. If I had started with ranibizumab before if I am on on ranibizumab, I may consider a trial of aflibercept in these patients, especially if they are requiring monthly treatment, because it's possible that lesser number of aflibercept injections may be needed. Now, in case you've started with 3 loading doses of aflibercept followed by a treat and extend regime in your patients who are stable but not dry, the objective is to see whether there is a possibility of maintaining greater than 8-week intervals. And if we don't reach that, then we don't get any major benefit from the aflibercept. So this is just to show you a patient who received 3 loading doses of aflibercept. And after that, we thought that we'll try to maintain on eccentrics, gave 1 injection, but he got a recurrence despite the eccentrics, shifted to aflibercept, but was requiring aflibercept almost every 6 weeks. And that's when we decided. So this patient was then maintained on 6-weekly aflibercept, and the patient has now been on aflibercept for quite some time. Now, the important thing is that when you initiate the treatment with aflibercept, you may not get a completely dry lesion by 3 injections. Well, we used to think we would, but we didn't get that when we actually practically did it. So if you've given the initial 3 loading doses of aflibercept, and after that, you find that you put the patient now, you've got a dry lesion, you put this patient on treat and extend the ranibizumab for maintenance. On the other hand, if it did not dry after 3 loading doses of aflibercept, you have to just continue with aflibercept and try to see what is the maximum interval between injections that you can reach, and try to limit the total amount of exposure to aflibercept, as I told you why I want that. But if you find both aflibercept and ranibizumab require 6-weekly injection, then my choice would be in favor of ranibizumab to avoid excess of a more powerful drug. Let's put this all in perspective now. You started aflibercept as first-line treatment. At 3 months, or the lesion, whenever you've started, you continued, you reached a dry lesion, you put this patient now on treat after your loading dose on a treat and extend ranibizumab. You are able to reach a treat and extend of 8 weeks or more, maintain on this. You're not able to maintain on 8 weeks. The patient needs the injection every 6 weeks. Then go back to treat and extend aflibercept and see what is the maximum duration of intervals that you can get. If it is more than 8 weeks, that's the way to go. If you can't do that, then between ranibizumab and aflibercept, choose ranibizumab. The second group of patients, stable but not dry, start with treat. You will now need to go to treat and extend aflibercept, see whether you are able to reach an interval of greater than 8 weeks, and if you can, maintain on treat and extend aflibercept. If you can't, try treat and extend ranibizumab. Now, the reason for creating this chart is if both aflibercept and ranibizumab are needed 4 to 6 weekly, then I would prefer to give ranibizumab in this situation. This is if after giving an adequate trial of aflibercept, I find that I'm still needing to give it 4 to 6 weekly. Then this is the way to go. Now, what about patients who've already been treating? They've received 3 doses of ranibizumab, now requiring PR in ranibizumab 6 weekly or so. So this is where you try aflibercept on a PRN basis. And this is what we did in this patient who after responded very well to the first injection, but then required injections virtually every 6 weeks with ranibizumab, was shifted to aflibercept. And we found that we could increase the durations between injections. Initially, the recurrence was occurring 8 weeks later, then 10 weeks later, then we gave it another try to see whether we could increase it after 10 weeks, but we got a recurrence at 12 weeks. So we went back to 10 weeks, and this patient has been maintained on 10 weekly treat and extend injections He now has passed away, but till he was there, he was being maintained on this treatment and he was doing very well, maintaining 6/6 vision. Now, the other important thing is when you decide to stop for a dry lesion, you must have at least 2 consecutive OCTs with no fluid before stopping, especially in patients who are responding after multiple injections for the first time. In a recurrence, I would stop. If after each recurrence, if they resolve, I would stop. I would not give more injections. Now, do we really want to dry the lesion completely? Yes, I do. And the reason comes from the Altair study, which showed that eyes which became dry at 16 weeks had double the visual improvement at 96 weeks, 9.1 letters as compared to 4.3 letters for those who were not dry at 16 weeks. Not only that, the number of injections decreased from 11.8 in patients who had fluid at 16 weeks to those to requiring only 9.4 injections in patients who were followed up for up to 96 weeks. The other important thing is that the longer you keep the lesion dry, the longer the intraretinal cystic cavities do not reappear, the better is the visual outcome. And this came from a post-hoc analysis of the EXCITE study. And this is extremely important for us. And finally, in the Hawk and Harriers trial, they divided the patients, all the patients they had in the study, into those who had high disease activity, meaning those who had the 25% of the patients with the highest mean intraretinal fluid, mean subretinal fluid, and mean PED volumes, and put the other 75% in the low disease activity group. And what they found was very clearly the lower level of fluid, whether it's intraretinal fluid, subretinal fluid, or pigment epithelial detachment, was associated with a better visual outcome, even if each was taken individually. That means regardless of all the other fluids. And therefore, it's extremely important for us to try the lesion to the extent we can. The other important thing that came out was that in patients who had less fluctuation in the thickness, the visual results were better. So the quartile with the least fluctuation in the central subfield thickness had maximum vision outcome as compared to the group, the quartile 4, which had maximum fluctuation in the thickness. So it's important not only to try to dry, but if you can't dry, maintain it stable with minimum fluid. Ladies and gentlemen, I want to set at rest one thought which is coming into people's mind, that maybe a little bit of fluid is good. Not really. Our acceptance of some fluid is a sign of a fox calling the grapes sour because she cannot get them. We are making a virtue out of necessity. That last bit of fluid is recalcitrant to treatment, so we say it is good for us. So that's accepting a fait accompli to make a victory out of our failure. Our objective is to dry the lesion. We do not want to have any fluid, but when it doesn't dry, we do the next best thing. We find out the minimum number of injections that prevents the fluid from increasing and accept that as our next achievable objective. This ensures that the number of injections is minimized over the long term without compromising visual outcomes. Ladies and gentlemen, today we have many drugs: bevacizumab, ranibizumab, aflibercept, and brolucizumab, and you will notice they are progressively stronger in their potency. We need to choose the drug which is best able to dry the various types of fluid more effectively, more consistently, and more safely. And that is the ultimate objective of treatment of ARMD, and the strategies which I have defined are meant to ensure that. Thank you very much, ladies and gentlemen.